If I could ask you to take your seats. I've just noticed we're already running late. My fault, sorry. So this is the second free-paper session of the conference. My name is David Long. I'm chairing the session. We've got three free-paper presentations for you in the next hour. The first is from Rosaria, Caforio and Deumayne-Jones, and it's entitled Posture Management in Movement Disorders, a Case Study. Rosaria, after college, worked as an orthopaedic technician for over 10 years with clinicians, biomedical engineers, mechanical engineers, universities, OTs, physios, patients, parents and caregivers, much as we all do, I guess. For the past 16 years, Rosaria has managed Pro Medicare, based in Italy, and at that company she's developed and manufactured a range of positioning systems. She's the author of several works accepted in national, European and international congresses and symposiums, the last one being a poster entitled Pelvic Total Support and Trunk Total Support, Groundbreaking Approach to Posture, and that was at the 29th International Seating Symposium in Nashville. Ian, with a UK and US engineering background, embarked on a career in healthcare in California as a technical trainer within the rehabilitation and respiratory sectors, returning to the UK in 1991. Now with over 25 years experience and grey hair, apparently, in special wheelchair driving controls and high-end active wheelchair project design and specification. In 2010 he launched the UK and Ireland division for a dynamic seating product range to supply configurable and long-term positioning and posture solutions. Over to you guys.
Good morning to all, and I hope my English will be comprehensible for you, and I introduce our work today. This work will introduce one of the main issues, one of the main problems when you have to take care about positioning, the movement disorders. As a bibliography, we look at dyskinesias as fast and involuntary movements, often qualitative, repetitive and stereotypic partners, combined to an alteration of the sensory motor mechanism, to indicate no loss of muscle strength, present a qualitative alteration of the movements, or generate abnormal posture and movements. And the key words for these dyskinesias are violence and instantaneity. But it's not written here. We have to take into consideration perception that play a big role in these users. Here, when we look at the dyskinesia manifestation, we can look at different abnormal movement and posture. And in these slides, we wanted to show you three different users with different movements and different partners. If you look at this guy, it's totally rotated and he pushes with the back. He can't sit, he can stay sit and push with the back and with the feet on the foot plates. These other guys, you will see, is a totally in movement. He can sit, but he pushes on the pommel. This other guy stressed the wheelchair, especially the headrest, and you will notice how he pushes strength within the headrest and the foot plates. This is for explaining you how it's difficult, how are different this user, and how it can be difficult to manage a solution, to create a solution for this. Because you can imagine it's not possible to create a standard solution. They have to be something really customized, but something that can create the comfort for their movement, for their stability. we have a lot of consequences, especially in the user, caregiver, and family. For the user, the risk of injuries is very high and clinical implications. Pain and discomfort, loss of posture, reduction of function and participation. For caregiver and family, you will see increased burden, deterioration of behavior, increased stress and risk of burnout, social isolation, financial impact. For economic and environmental, increased funding, increase of resources and time, discrimination, and often frustration because can't arrive at a solution.
I hope also my English is understandable. I'll keep my accent as plain as I possibly can. Okay, so with this project, our aims and objectives were to describe the process of putting together a collaborative team and a number of materials and products into one package to provide this case study a general improvement in his posture and comfort, to reduce and control and manage the extensor thrust and maybe limit the frequency and the intensity of the thrust, and also then to try and halt and manage the progression of the deformity that you will see later on. And of course, the big one, reduce the risk of injury and the social cost. And the social cost is not just financial. So here we have our case study. It's a young gentleman by the name of Ian, who lives in a very remote area of Scotland. So you can understand that the support necessary for him perhaps is even more intense than somebody in the centre of a large city. Ian has CP, and as you can see from the far left photograph, has an anteriorly tilted pelvis, severe lordosis, very high extensor tone. And the problems surrounding Ian and his family are frequent and severe damage to wheelchairs. That can be something as simple as a bracket fracturing or a headrest bracket fracturing to complete wheelchair frame failure. Postural discomfort and the behavioural issues that follow this. Ian was constantly in pain, very uncomfortable, and he showed that through his strength, through his extensor tone. Poor management of the control and the progression of the deformity. We felt that the lordosis would become worse, there wasn't enough support for him, and therefore the knock-on effect would make it even more difficult to manage. And of course, from the family and the caregivers, extreme levels of support, high levels of burden, and a lot of frustration also. So now starts the quest. The idea was to build a team, a collaborative team with multifunctioning skills and disciplinaries, bring together and have first a meeting with the caregivers and family to set goals, to find out what they are looking for, what is best for Ian for now and in the future. So the equipment suppliers, Rosaria and myself included, along with our local supplier in Scotland, a number of clinicians, some working within the NHS, some in the private sector, all of the family and all of the caregivers, all of the carers that came in to take care of Ian were involved in this. And we were all shepherded expertly by the case manager from an organisation called Head Start.
We approached to this case as a research because we have seen how different are these users. The goal of this research was to build a machine designed to balance the body and the gravitational load by complying with the dyskinetic movements and the perceptive state of the patients. Equipped with materials and mechanisms shock absorbing, to guarantee a safe position, an harmonious and an homogeneous surface of support, adhering and relaxing, and the beginning of a rehabilitation project useful and possible for the user. For the seat, we used the approach of a PTS, pelvic total support. It's a customized creation built from a standard solution that can adapt to the pelvis and starting from a flat base of construction made with a different insert that create any time a different shape. It is made with different kind of materials, rigid and semi-rigid, and different type of foam, memory and viscoelastic, expressly combined for meet the perception acceptable. For the backs, we use the same concept, but for the trunk total support. And in this case, we create a built-in solution, customized solution, where we combine a lateral and lordosis profile with the size of the user, and we use the 4.5 centimeter of thick memory foam and elasticated cover for contour of the lordosis, and create a dampening, some slow memory when the thrust come, and they can create something to follow the movement on the surface of the support. For the wheelchair, we used Adacta Klim frame that is a modular frame created in aluminium, where the key concept was to manage and absorb extensor movement, reduce muscular contraction, with ensuring correct postural positioning and reduce load of the wheelchair and seating system. Shock-absorbing backrest to allow for the rear trunk movements and a fluid return to a starting position. Shock-absorbing leg rest and foot plates allow for both download and forward extensor movement. Because have you seen this guy start the movement for feet? So we try to break the movement, the extensor tone from feet, and reduce the impact on the shoulder and on the head.
Okay, so now we're looking at the schedule that we put together. And the first part was the initial assessment, where we took a lot of time looking at past history, a lot of personal detail. We then went to a product trial where we did a fitting of the configuration so we know we had something that would work. Then review the system, make a small adaptations, some small changes, and then set the protocol for the transfer into the chair, what position he must be in, and how to transfer, what position the chair must be in for a decent transfer. And then, of course, on the follow-up, we record every change, all the details in photographs and everything else. This is Ian, T3. This is the final fit and handover. As you can see, good symmetry. Enhanced head control. Ian is now beginning to use his own method, exploring the dynamic chassis regularly, but always maintaining a good position. And this is a quick video of Ian. He uses the chair. Now, normally when we first met with Ian, this extensor tone was driven, we think, by discomfort and pain. Now we notice very handily that there's one particular carer that produces this, and she's a very attractive young lady, so Ian has good taste. This is the follow-up review. So we notice a reduction in intensor thrust episodes, the frequency, but also in the intensity. We have a good positive effect on his function, now that he's learning to use controls now to operate televisions and things like such. No more back pain, no more medicine, and a small increase noticed by the surgeon in voluntary tone. And this is the last time in the video here. Sometimes we wait for an hour for Ian to expand, and he does it normally as we're about to walk out the door. Okay, so our discussion points are around the collaborative method, nobody hiding behind their own product. Multidisciplinary teams, bring in the resource right at the start of the project. And then these people can fall away and drop off as we get the solutions. Note also that the body structure changes constantly, from week to week to week. Adapt the seating system accordingly, so you have to have something modular. Look at the materials you're using and the combination of those materials. And then obviously then look at what stability and comfort can mean to the quality of Ian's life and his family's life. Thank you very much.
Thank you for that presentation. Do we have any questions? Could I ask you please to state your name and where you're from?
Hi, it's Tim Adlam from Bath Institute of Medical Engineering. I'm curious as to the characteristics of the springs that you used for the backrest and for the feet and so on as well. What kind of displacement curve or straight line did they have, and how much movement was allowed, and how was the movement limited?
The actual fact is not a spring, it's a gas strut. It's a gas strut. And the gas strut we have in two different values, 200 Newton, 250 Newton. But we can also lock the position of the back to where we get the angle that we want, and then the movement. Okay? So, along with the foam, the different thicknesses of foam and the different type of foam, we absorb the first part of the movement, and then the gas strut takes care of the next part of the movement. On the foot plates, same theory, the downward force and outward force, but on occasions we've also used a double thickness foot plate with some springs in the middle. But this again acts as dampening, so it takes the impetus away from the thrust. Is that?
Yeah, the gas springs, and I know what gas springs do.
Other questions? Just over on the left side there.
Yeah, Coach Service. Does Ian travel in the chair, and do you have to lock it off when he's in the vehicle?
This is probably the most difficult area. As a company, we decided that it was pointless to try and crash test the Klim for two reasons. One, it's dynamic, it moves, and therefore will fail the test. To lock out the back is not such a difficult thing, but to lock both angles of the foot plate is very difficult. We did a risk assessment along with some people in the transportation industry, and we felt that to have a driver or a person responsible to lock all three components would never happen. So we have performed a risk assessment instead, to where Ian travels privately in the chair, but when he uses his council bus to go to school, he goes back into his old chair, which then makes him extend, and the driver is concerned that there's going to be damage in the bus. So in short, it's not legal to travel from a council point of view.
I think we should perhaps discuss this topic in the transportation parallel session this afternoon. Any more questions? Could I ask a brief one, and that's about the multidisciplinary team? It sounds wonderful. Did you have any barriers to making it work?
No, not really, because the parents were very frustrated by this time in getting their son a solution. So they researched the type of people that they wanted, and then, as I said in the presentation, we had a lady by the name of Helen Drury, who is the case manager for Ian from Head Start, who just wouldn't tolerate any partisan feelings, wouldn't tolerate anybody saying, I think you're wrong. We just focused on Ian. So I would be lying to say that it was all super smooth and we all love each other and we send each other Christmas cards regularly, but it worked for Ian, and that's the key thing.
Any more? Just one up front, and we'll make this the last one.
Rashid Physio from small private hospital. Sorry, just the idea is very interesting, but I do have some of my patients who have the same problem, who are easily managing standard wheelchairs like Rosaria. Or I'm not sure if such mechanisms are a feature in any of the standard models?
We would say with Ian, after 1 year, I think we have enough experience and enough data now to say that actually perhaps the cushion and the way it's stabilizing his pelvis is probably 50 to 60% of the solution. But as you can see by his movement, this in any other than a dynamic chair, I think eventually you would get fatigue, you would get breakage. We do have clients who we've started off in a similar protocol, and after 6 months or 1 year, their extensor tone now is such that something like the dynamic chair is not necessary, and we would go back to the regular tilt and space type product. So I think it depends how you manage the thrust and the intensity of the thrust.
Rosaria and Ian, thank you very much.
Thank you. Thank you.
Our next presentation is from